Welcome to the Jack Westin MCAT podcast with your host, Phil Hawkins.
And Azaii Calderon Muñiz. Welcome, everyone. We are continuing our review of the AAMC Psych outline. Namely, we're still in 7A. We are going through the psych disorders, and hopefully you're staying tuned because you're not just studying for the MCAT, but you also find it interesting the way we find it interesting. So today we're going to be talking a little bit more about the mood disorders and the psychotic disorders. So we're going to be talking about bipolar, depression, all of the associated disorders in that realm, as well as schizophrenia. I don't know about you, but I'm really excited for this set of disorders. I think it's because one of them is one that most people are familiar with. One of them, there's a lot of misconceptions, and the other is just really interesting.
Looking at all of the lectures that we've done in the psychological disorders, this is the one that is probably going to be the most useful to you as a physician, because depression is the number one psychological disorder in terms of prevalence. And so that, a lot of people have some ideas of bipolar. You're exactly right. A lot of people misunderstand, and schizophrenia is just kind of out there and weird in the ways that it can present with so many different ways. It's really tricky. So I'm excited to talk about this because this is going to be useful and interesting, which is exactly what I want everything to be.
Exactly. So we're going to start our conversation today with bipolar. So the bipolar disorders and then the different types, right? But before we get into the specific types, I think it's useful to address some of the misconceptions. So I'm sure most people at some point in their life have heard someone say, that person's so bipolar, right? Referring to someone who changes their mind a lot or just goes back and forth in a day in terms of how they're feeling, something like that. Whereas with the bipolar and related disorders, it's not that someone's just changing their mind all of the time. It's a very significant change in mood and affect and the way that they are interacting with and experiencing the world. So these disorders there are three main components that go into deciding whether it's type 1, type 2, or cyclothymia, which we'll also talk about. And that's the idea of a manic phase, a hypomanic or a manic episode or manic phase, hypomania, so hypomanic episode or phase, and then depression. So with think about what each of those correspond to. We'll talk about hypomania when we're talking about type 2. But with type 1, it's really the presence of a manic episode or mania. And so we have to start wondering, what is mania, right? So I'm a big fan of mnemonics. Anything that will help me remember something better is huge. And so before I go into the mnemonic, I'm going to present you with a person, right? And I'll tell you some of the stuff that they're doing. And Phil, if you want to chime in terms of, I think that this is what we're seeing in this patient, feel free. So this patient walks into your office, right? And you immediately notice that they're looking around, right? And you're trying to have a conversation with them. And it's really hard to keep them focused on the conversation. And whenever they do start talking to you, you notice that they're talking super fast, almost like they have all of this energy and thoughts that they're trying to get out and they can't seem to get them out fast enough, right? And you're you start getting a little concerned. You're what have you been doing the last few days? And they tell you, I have been writing a book. I discovered a new planet, and I think it's so important that I write this book, and no one else is going to know what I'm talking about, but I know that I'm right. Right. Mm-hmm. And then they're like, you know what? I don't even need to be here anymore. I'm going to go. And they start leaving the room, and you ask them where they're going. And they say that they are going to go buy a truck and they are going to travel across the country while writing this book. Right. That only they can write. And so you're like, okay, have you been sleeping? Are you, what's going on here? And they're like, I don't need sleep. What are you talking about? I don't need that. I've been good. I've been great. Well, how long have you actually been sleeping? I slept 3 hours last night.
Right.
What? Right. Yeah. So let's think about some of the stuff that, that might be present in this mystery patient. So, Phil, what would have you concerned if a patient walked into your office like that?
Pretty much everything. So you're talking about like, this is obviously a very manic phase here, and there's a list of like criteria and symptoms you can use to this. But I think for me, it's always easier to just think about cocaine, right? Like at least the depiction of cocaine in the world, like people are so excited, I'm going to do all these things. I'm so excited. I'm going to do so much stuff. I'm on top of the world. Everything's great. And they're like moving so fast. And it's so hard to get them to just like slow down and calm down. But like, turns out people can be this way without cocaine, which is what we would, and like cocaine does cause these manic things. But like talking through this, it's like a really interesting case. And like after you meet a couple of these patients, you're like, oh, I got it. Like it kind of to jump out at you.
Yeah. I like that you pointed out, like, you know, they're like getting them to calm down would be really difficult, right? They have like this very intense experience that they're presenting with, right? So they haven't slept. So let me back up a little bit. The mnemonic that we use is dig fast for a manic episode. So the first thing that this person, that our mystery patient, presented with was distractibility, right? And that's the D in dig fast, right? You can't keep them focused. Impulsive, right? So I for impulsivity, they're going out and they decide that they're just going to buy a truck and drive across the country, right? Grandiosity, they're pretty sure that they're the only person that can write this book. The flight of ideas, right? So their thoughts are going everywhere. And then, so with A, it's like this activity or goal orientation. So they're writing that book and they have all this like focus for this book that they're able to do. They didn't need sleep. Right. So decreased need for sleep. And it's not just, oh, I don't want to sleep. It's like, I don't need sleep. And then T, the talkativeness, which is like you were saying, like, it's really hard to get them to slow down. Sometimes I have to remind myself, I'm like, okay, I have to slow down in the way I talk in general. Right. But like these patients are going really, really fast. So
it's funny you mentioned that, because I literally was, as you were saying, like I do this all the time when I'm lecturing on physics, and I'm like, there's so many cool things going on here, and I'm like, I want to get all these ideas out, and so might go into a mini manic episode whenever I'm teaching fluid dynamics.
Yeah, I have to keep reminding myself, like when we get into these conversations, I'm like, okay, slow down. But yeah, and I like that you pointed out that, you know, it's for you, like you just remember, okay, what would someone be like when they're on cocaine, right? And so that is actually something that you would have to rule out if a patient comes in presenting this way. So I think that's a, you know, really great point. So for someone who is has type 1 bipolar disorder, that's what they might be presenting with during a manic phase, right? And so they just need one manic phase. They have type 1 bipolar. So they have this really elevated mood. They might be irritable, but they have a lot of energy and activity, which we showed, you know, all of that in our mystery patient presentation. And it's actually not, so bipolar in general isn't the most common of disorders that we'll see. It's maybe like a 3-ish%. So like, you know, fairly low, but still more than some of the other ones we'll talk about. Just not as common, for example, as depression, but not entirely uncommon.
Right. You know, 3% sounds really low, but then you realize like how many hundreds of people do you know? And you're like, okay, well, every time you have like 30 people in a room, probably one of them is bipolar. And that all of a sudden puts it in perspective. Like you've probably had several of them as classmates, you know, as you go through your career, like dozens. I do like bipolar. Just kind of overall, like stepping back, like the idea behind bipolar, it used to be called manic depressive. This is another one of those ones that changed with the DSM-5 name change stuff, because this is a mood disorder. And like to take just a second, because I know a lot of times students get confused on the difference between mood and emotion, and like anger and fear and sadness and joy, and all those are emotions. And so we're not talking about necessarily things related to that. We're talking about things related to mood. So mood, instead of being like, so like emotions, they're like discrete things, and you can be this or that or this or that. And like, they're not really related. Like there's not really a relationship between happiness and anger, like jealousy to something else, versus mood is it's kind of a spectrum, like towards the higher moods or the lower moods, like a good mood or bad mood. And so just kind of like feeling good or feeling bad. And so with bipolar, it's a mood disorder. So they're moving between these two areas. So having like a good mood, even further than that is mania. And so like a really good mood, everything is great. And then down on the other end is depression. And so don't like, I know a lot of times students will see things about like quick emotional changes, and they'll be like, oh, this is a mood disorder. Like, nah, it's probably something else. Like maybe something we'll talk about next time or the time after in like psychological disorders. But you want to be able to kind of like pull that apart, which is kind of interesting. Now, as you mentioned, bipolar 1, like doesn't actually, so bipolar overall, the idea is like you swing between these two poles, but bipolar 1 we've come to define as just like mania with or without the depressive stuff. If you've got a lot of the depressive stuff, then there's things going on there. So moving past that, we also have like the bipolar type 2, and then we have cyclothymia. So bipolar type 2 has the very low swings with depression, and it has some upswings towards mania, but it doesn't go quite as high. And so like the mania is not as manic. And so we call it like a hypomanic, hypo meaning less than. And so it's just a little bit less on the mania side, but you still have these swings back and forth, versus cyclothymia is like hypomanic, but also like a hypodepressive. So you don't have like the full-fledged depression that's really extreme here. So if somebody had like crazy high mania and crazy low depression, that person would be a bipolar type 1. What's interesting is that even though that disease is a little bit more severe than like, let's say bipolar type 2, where they still have the low lows, but their highs aren't as high. People with type 1 are hard to treat, partially because they don't want to be treated, because the mania feels so good. Like I'm on top of the world. Like everything is great. Like it feels good. And so a lot of times these patients don't take their medications like they should, because they take their medications. It brings their lows up. It brings their highs down. And like losing those manic sessions is a little bit difficult. Versus bipolar type 2, they don't have as high of highs, but they still got the low lows. And so you end up seeing a lot more adherence to like treatment with bipolar type 2 and cyclothymia as well. But like, once again, cyclothymia is a little bit less severe. And so I think actually a lot of cyclothymics don't get diagnosed. I think this is another place where, people feel shame about psychological disorders overall. And so they don't go to doctors and they don't go to things. And also people just aren't aware of these, right? Like if you feel pretty good on some days and pretty bad on other days, and this is just normally how your life has been, like what at what age do you say like there's something wrong with me, right? Like if you've lived with this for 20 years or 15 years, all of a sudden it's kind of hard to realize, because once again, a lot of times these things are like lifelong. These generally tend not to be things that are like you become bipolar at 30 for like 2 years, right? Like that's not generally how bipolar works.
Yeah, and I'm really glad that you've been pointing out, whether explicitly or implicitly, the impairment of function, right? And like how that's going to impact the person. So with, like you pointed out with type 1, right, where we have this like manic phase, these are prolonged, right? So the person might be having a week, 2 weeks more of this manic phase. Oftentimes they'll end up having to be hospitalized, right? Because it's so intense, it's functionally impairing. And that's how a lot of people with type 1 get diagnosed, right? Because they ended up having to be hospitalized during a manic episode. Whereas with type 2, hypomania, these patients really don't usually require hospitalization, right? So they're still having that upswing, but it's less than the manic episode. Whereas like someone with cyclothymia may not even get to that point. People may not even realize that, they're having these episodes, because it's a lot easier to recognize someone in a manic episode, right, than someone in hypomania. And even then with hypomania, you can, usually still tell. But if it's a more chronic and something that you've seen as, oh, they've always been like that, right? Because bipolar often will get like, it'll start presenting, like people get diagnosed like their 20s, right? So it's like, oh no, they were always talkative as a kid, right? Oh no, they always had like a lot of energy. So it can be harder to diagnose. And I think that's a really great point. That it's very easy to forget sometimes. I think we mentioned this during our last podcast or the one before, but a lot of these disorders are based around the impairment and their effect on the person's interaction with the world. So the way that they taught us to kind of distinguish type 1, type 2, severity of that presenting hypo or manic episode. If it's enough to really impair their functioning with the world, they err on the side of mania, right? If not, err on the side of hypomania, and then cyclothymic, just kind of like that in between between the two.
Yeah. Just
Or
one
not between
little,
the two, excuse me, between like the mild upswing
right.
and mild downswing.
The like one last thing about like the mania, like a lot of times, like if depression is so bad, like the other side being mania, a lot of times people are like, that seems like a good thing, right? Like like you're like, it's the opposite of depression, right? Like if I ask like just a normal person on the street, the opposite of depression, is that a good thing or a bad thing? Everyone's going to say a good thing. And it feels great when you're in a manic episode. Generally people accomplish a lot of stuff, and they like, maybe that person actually did find a planet, maybe that they might have, right? Because they weren't sleeping and they're staring in the telescope all night and they're like doing stuff. And like, maybe there is actually something being accomplished there. And so, you know, like that sounds like someone who's just like on top of it, getting so much stuff done. But a lot of times with this mania, we have this illusion of invulnerability, and you're only ever looking at what can go right and you're not looking at what can go wrong. And so that's why a lot of people with bipolar 1 end up in hospitals, because they're like, oh, I can jump over that chasm. Oh, I can do this. And like they end up in the hospital because of something that happened to them when they were in a manic episode. And it wasn't exactly like, oh, they went to the hospital because they were manic. They went to the hospital because they broke their legs or because something else. But also a lot of times, like if you only ever see positive outcomes and everything that come out of this, and you don't do proper risk assessment, you can end up with some issues, like people like taking all of their money. I heard a story about a person who took all of their money and bought an emu farm because they were going to sell emu omelets at their own bed and breakfast cafe thing. And this person had never lived on a farm. This person had never owned a restaurant. This person had never like owned a hotel or a bed and breakfast. And they just decided one day that I'm going to, like, all my life savings, I'm going to throw into this thing. I'm going to buy a bunch of emus and try to learn to corral and get them to lay eggs and learn to cook with their eggs. And like, they never even tried an emu egg omelet, which evidently is not tasty. And so there's like, this is, like there's some mistakes. It doesn't have to be like bodily, but like some big picture stuff. And so if you, there's these people out there that make these like very aggressive things, and it can be a little bit tricky because in the real world, like people have different levels of risk assessment. I am like, my best friend is completely risk averse, right? Like everything, he's always like worried about like, okay, this could happen or this could happen. So it's not worth, risking my job to try to get a higher paying job because like, I don't want to lose the job I have. And like, I'm on the other way. I'm like, no, I'm going for like I want to like accomplish as much as I can, but like doing this in a smart way, right? Like there's a difference between like, oh, I'm going to like, try to move up to management and like maybe move to a different company and become a director or something like that. There's a difference between that and saying like, I'm going to quit my job as a construction worker and become an emu farmer. And like, that's a little bit different.
Yeah. And I think that's also really important. I think we've presented this mania and hypomania and like, okay, you can still accomplish a lot, but I think that it's really important to remember like that I in impulsivity is, like you said, it's losing that ability to risk assess. People often lose their savings. They end up in a lot of debt during these manic episodes, right? So then they have to come back and rebuild entire parts of their life after these episodes. I think also something that, with like hypomania, it's like, oh, like, well, they're still being productive and it's not as bad as a manic episode. So really, what's the problem? A lot of times it's that downswing into a really bad depression following these upswings, especially if someone has like concurrent, right, mania and like type 1 with depression, right? So there's, we might say, okay, well, that's that increase in productivity, but it's coming at a really high cost, right? Yeah. Which is why it's impairing someone's like their ability to function. Yeah. So it's a very there's a lot of misconceptions about it, right? And it's not related to, it's not based on emotion, like Phil said at the beginning, right? It's not that they're changing their mind, once in a day or twice in a day. It's that it is a often basically lifelong mood disorder that goes back and forth very often between these very high highs and often very low lows, right? With very severe outcomes and risks that requires lifelong treatment, and with mood stabilizers, like you mentioned, and some like antipsychotics.
Yeah, the mood stabilizers. This is why, like, So the bipolar 1, they're the most commonly, I think they're diagnosed way better than any of the other ones are, because it's like very clear and they come into the hospital because of accidents, and like, like family will come in like, listen, like my dad just blew through all of his retirement stuff. Now he's like in debt. Like we need to like talk to him and like figure out kind of like what's going on. And like, so that happens, like bipolar type 1 gets diagnosed, I think, a lot better. But the treatment for that is mood stabilizers. And so that basically takes their lows and brings it up, and takes their highs and brings it down. And so they're kind of in like a normal middle range. But a lot of times, as I mentioned, patients don't like that, because like, yeah, you're getting rid of the depressive times, but you're also like, the times I feel so good and feel so on top of the world, like that's gone. And so they just, like, a lot of bipolar 1s don't like to take their medication. But bipolar 2 and cyclothymia, if you can diagnose them, they tend to be better with taking their medication because it helps with the depressive side.
Yeah. And in terms of the medications, right, we're having conversations about these. You're not expected to know like names or anything like that on the exam. So just kind of keep that tucked in the back of your mind. It's for our conversation here. But yes, and then one last thought with respect to medications. So with type 1, there will often be like a combination, right? So they may put on lithium, for example, and a mood stabilizer. What I want to mention with mood stabilizers is we're using them in the context of bipolar. They can also be used for other conditions. Mm-hmm. And so it's always interesting to think about that. And as you learn about medications in medical school and in your own life, wherever it may be, you'll realize a lot of medications have treatment overlaps,
especially in psych. Mm-hmm. Because I feel like in psych, it's very hard to like diagnose like what exactly is wrong. And so over the course of time, people will try like, well, this helps with this psychological disorder. Like, let's try it for this one. I'm like, oh, that actually seemed to help. And so like, there's a lot of things like SSRIs that get kind of like pushed into like a bunch of different things, and they kind of seem to help in a lot of them. But it's just kind of an interesting thing because there's a lot more overlap there in psychological disorders than there are in other regions of the body.
Yep. So now that we've talked a little bit about some of these upswings, we can talk a little bit about downswings. So thinking about the depressive disorders and depression related disorders. So here, right, we've talked about mania, and we've talked a little bit about, okay, well, the possibility of depression with like type 1 and type 2 and cyclothymia. So what really constitutes depression? It's something that we hear thrown out a lot. People will often say, oh yeah, like I've been so depressed. And then it's more related to like an emotion versus mood. Mm-hmm. So keeping in mind that we do in general want to be very careful about throwing terms around if we're not actually sure what they correspond to. But with depression, it's a much higher prevalence than the other disorders we've been talking about. So the lifetime prevalence and the lifetime basically like risk of developing depression for a woman is generally between like 10 to 25%. So like almost on the upper end of that spectrum, 1 in 4 women will develop depression at some point in their life, whether it's persistent or not, totally different story, right? But that's pretty high if you think about it.
Right. The 10 to 25 there is because like the diagnosing, the gap between diagnosing and people actually having it, because a lot of times people don't seek treatment. But yeah,
exactly.
So I would say it probably is closer to the 25 than the 10 in the real world.
And then with men, it's generally estimated somewhere between like 5 and 12. But I suspect, like I'm sure you suspect, the number's also probably higher in people just, because of like gender norms and like societal expectations. They probably seek out help a little less.
Yeah,
if not maybe a lot less, depending on where, like what the culture in their area is.
Right. Especially in like certain regions of the country. I feel like, like in the South or the Midwest, like men are not likely to even talk to a therapist, let alone like talk to somebody, who's involved in anything psych. But, maybe in like some coastal regions, it's a little bit less pressure there. Yeah.
And I'm trying to like back off on something else. I will think about it, or I will mention it later. But like, so you're thinking, okay, so what does a person with depression present like, right? What does a depressive episode look like? So I think a lot of people can generally say, okay, like the person's just been like sad, down, right? Feeling depressed for some time. So that's like one of the symptoms. They might have sleep changes, so they might be sleeping less, but they also might be sleeping a lot more, right? So we've definitely heard of people, who just can't seem to get out of bed when they're depressed. So that's like another way that patient might present. Less interest, less pleasure in the stuff that they're doing, right? They might have like feelings of guilt or worthlessness, have like a drop in their energy, right? These energy changes, have trouble concentrating. Some folks might be like, that's starting to sound like me, right?
Yeah.
So that's, like these are things that a lot of people experience at some point in their life, but they're also very intense during an episode of depression. They might have trouble eating, or they might eat a lot, right? So just these changes in appetite. They might have like motor or psychomotor changes and agitations. But then also folks might get suicidal, right? And so we often think, okay, that's the extreme. I want to touch base on that in a second. But if you've been listening to what I've been saying, I've essentially given you another mnemonic. And that's D-SIGI-CAPS. Again, you're not expected to know these mnemonics for the MCAT. If you can just remember 1 or 2 letters from them, that will help you realize, like remember what the symptoms might be. That's more than enough. So for someone who's experiencing a major depressive episode, right? So this is major depression. This is at least 2 weeks with 5 or more of the symptoms that I just gave, with one of them having to be, right, like that depressed mood. That's the key one in depression. Now, the reason I'll let you, I want to let Phil talk in a moment.
Yeah.
The suicidal thing I said, we often think about that as the extreme. I think we're recognizing a lot more that people with depression will often have suicidal thoughts that they don't intend to act on, and that can be really common. And so keeping in mind that, when you're in the future, when you're assessing patients, you always, even if they seem like they're okay, even if they're like, oh no, it's not that bad, ask about, like, do a suicide and homicide screen. Like that should always be the case. It's honestly the case with any patient who comes in with concerns for a psych disorder. Like you will always screen for that, but it's really important to keep that in mind.
Right. Especially considering how common depression is, as we mentioned. There is one of those terms that you like, this lack of interest in stuff. There's a specific term for this that I know has shown up on the MCAT, which is anhedonia. And so like hedonism, some of you guys may be familiar with the term hedonism. It's like Greek or Roman or something. I'm not a linguist. But that is like pleasure seeking sort of thing. And so like hedonic behavior is, people who like drink and sex and drugs and like just like pleasure is all we're looking for. So anhedonia means you can't feel pleasure. And so this is why there's a lot of misunderstanding of what's going on in depression. Somebody says they're depressed and you're like, well, why don't you just go do something fun? Right? Like that'll like, no, like that's not how depression works. It isn't just like, oh, if you put me in a room with puppies, my depression is cured, or if I'm on a roller coaster, my depression is cured, because it's just this constant permeating. And the anhedonia, the way that presents is you like lose interest and don't feel joy in the things that normally brought you joy. And so this person is now in a room with puppies or on a roller coaster, and they're still depressed, right? They still aren't getting a lot of joy out of it. And so this is one of the reasons that, people kind of like stay in bed or things like that. Like anything, like nothing brings any joy. And so why do anything, right? It's, they look at, like going to the park or playing with puppies or seeing friends. That's the same as like running 6 miles, right? There's no joy that comes out of it. It's just work. And so make sure you know that term anhedonia and this lack of the ability to feel joy in the things that normally would bring you joy. You always have to like phrase it like that, because there are some people that just hate dogs. And so a room full of puppies seems awful. That doesn't mean that they're depressed, but if they normally would love to be in a room full of puppies, like I think most people would, then, and now they don't feel any joy from that, then that would be a way to do that. Now I want, like, if I ever have a clinic, to have a room full of puppies just as my diagnostic test for depression, just because then I'll just have a room full of puppies, which is really all I really want.
Can you add a second room for kittens?
Right.
For those of us that like
or
Think kittens
allergic
are
to
the cutest
dogs,
thing.
or you're right. Yeah. Something, some switches there.
Yeah. Yeah. And so we've kind of presented like the extreme, right, of a major depressive episode. There are folks who will also have less severe symptoms. And so this less severe version, we call it dysthymia. And so someone might have dysthymia for years, right? And so when they have that for at least 2 years, it becomes persistent depressive disorder. And so at that point, right, it's not that they're having a major depressive episode, it's that they have this like chronic lower mood that's not like full blown all the way, intense depression. And so there's like some more diagnostic criteria that you really don't need to know, but the with respect to major depressive, right, that's the like high of the high, and maybe not high, I shouldn't use that word.
Yeah.
The intense of the intense, right?
Right.
And then dysthymia is less intense, and it can persist for a long time, or it can be shorter duration.
Right. And once again, a lot of times dysthymia, or persistent depressive disorder, as it's sometimes called, is not diagnosed as well because it's not as extreme. And so you just kind of feel down all the time. Like you still are functioning, like maybe a little bit better. You're not trapped in your bed for 3 days, but you just don't get a lot of joy out of what you're going through. There's one more depressive disorder that we want to talk about, and that is seasonal affective disorder, which is something that I definitely go through, especially when I was in med school. So this taps into the idea of light, which is kind of strange, right? This is where the physics comes in. This is why this is one of the good ones. It's a physics related one. And so light, hitting our retinas and our skin, it changes things in our body, like stuff with vitamin D in our skin, and like eventually, creating turning tryptophan into serotonin and melatonin. And so because of this relationship, especially with serotonin, probably, we see like light affecting people's mood, right? And so a lot of times, especially during winter, when there is less light out, people will sometimes get depressed. And so this like seasonal affective disorder, it's seasonal. And so people tend to get more down in the winter, kind of overall, especially at higher latitudes in the north hemisphere, in the southern hemisphere, the lower latitudes, basically the farther you are from the equator, because the farther you get from the equator, the less light there is in the winter. This is something, as I mentioned, in med school, I definitely dealt with this because I would like go to the like the med school, and it would be dark out, and I would study, and I'd come home and it would be dark out because it would be like such a long day. And so I think, and like it'll be like cloudy a lot and like snowy, and just like you don't want to be outside anyway in the light. And so I think that there's there were some good weeks in there that like I don't think I saw the sun at any point during that week. And this is something that you want to be really aware of as a thing, because I think that this is once again, more common than it is diagnosed. But like something that's really interesting is one of the therapies for this is just light therapy. And so you can buy special lamps and special lights that will emit light in the same spectrum as the sun. And you can put that in your room or your office as you're studying. And I got one of those, and it actually helped my mood pretty severely. I know a lot of med students end up getting those once they learn about it, because they're not actually that expensive either. And that's something that is kind of interesting. You have to be careful, because if you like leave it on like late at night, it'll definitely mess with your sleep schedule as well. But kind of an interesting thing there.
Yeah, when you mention them, I'm like looking around to see where mine is.
Yeah.
Yeah. So actually, I think that's a really good point. So I think people often think like, oh, like people are just exaggerating when they say they get depressed in like the winter. Like, no, this is a real thing. It can be very intense for a lot of people. I remember when I first moved to Chicago for undergrad, I started feeling a little down. For reference, I was mostly raised in Florida, right? My parents are Puerto Rican. Like I'm used to sunshine. I don't do a lack of sunshine well. And so when I moved to Chicago, I was like, this is kind of sad. Like there's no sun out here. And I didn't really register that I was getting sadder necessarily. And one of my advisor at the time, was just like, yeah, no, a lot of students, when they come from other parts of the country, they tend to get really sad during the winter here because you're not going to get a lot of sun. And they were actually the one that introduced me to the concept of seasonal affective, seasonal affective disorder.
Yeah.
I was just like, wow, that's a thing. And they actually recommended the same thing. They were like, oh, get yourself a lamp so you can just avoid this whole issue. And so I remember I got one of those lamps. I think it was like $15 at the time.
Yeah, they're not expensive.
Yeah. And you can actually set them up so that they stay on for a certain amount of time. And then you set it up and you wake up with it. And that's the key. And so I think mine I used to be able to program it or I would turn it on a specific time. As soon as I got up, I would just press the button.
Mm-hmm.
But like Phil said, you definitely don't want to use those at night. It will screw up your sleep schedule.
Mm-hmm.
And so something else is actually, people are often told to take vitamin D when they have SAD. And so that goes back, it reinforces this idea of, okay, something with respect to the light is what's, allowing for people to not end up with SAD. And then when you remove that light, that's what can precipitate SAD.
So the role of vitamin D in there is kind of tricky, I feel like. But if somebody's not getting enough light that they have seasonal affective disorder, then they almost certainly aren't getting enough light for their vitamin D levels. And so, yeah.
Yeah. And it's really interesting because, I just find it very interesting. In case you haven't noticed, I find a lot of psych disorders interesting. Mm-hmm. In case someone is about to ask, no, I'm not thinking of going into psychiatry.
Right.
I get that question a lot. But it's honestly, it's very interesting. Right. And so I think that just when you're studying for the MCAT, get into the habit of in the morning, open those blinds, right? Don't pull a med student, because I have been one of those med students where you just lock yourself in your room to study, or wherever you go to study. We've always talked about this. We believe it's very important. As you're studying for the MCAT, make sure you're doing it in a sustainable way. Make sure that you're getting enough sleep, that you're exercising, that you're socializing to an appropriate amount, that you're eating well, right? All of those things are important. Light is important.
Yeah. So especially as we talk about, this depressive side is the other side of mania. So if mania makes you really accomplish a lot, then depressive tends to be people are tired and low energy and they don't have the energy to do stuff. And so if you find that all the time you're I should be studying, I just don't have the energy, I don't want to, I can't get myself to do it, getting a lamp, that sounds really silly. Buying a lamp might help and might actually make you accomplish more with your studying. And I feel like that little tidbit is going to resonate with everyone who's studying for the MCAT, because everyone's trying to get more studying done and be more efficient. And so I feel like I should buy stock in the companies that make those lamps right before we launch this episode.
Yeah, it's Amazon. You want to let us know something?
Right.
But before we move on to schizophrenia, I just want to say one last thought. If you have been listening to us at any point in time, and if we're going through a disorder, and mainly depression, just because it's very common, and you're saying, okay, this sounds like me, and I'm noticing that I'm having trouble doing the things that I need to be doing, right? You have this impairment, reach out to a doctor, reach out to someone, and make sure that you're trying to get the help, whatever help you can get, because we've said before, you shouldn't have to go through a disorder, a disease, an illness, anything, without trying to get help as much as possible. So right. If what we've been talking about is resonating, try and reach out to someone for help. That's
such an important thing to point out, because even if you've been a practicing physician for 30 years, you're kind of not allowed to diagnose yourself with stuff. You need to talk to somebody else and kind of work through, because there might be some other things going on. Because once again, a lot of these symptoms could be related to other stuff, right? Having really low energy and being tired all the time could be a thyroid issue, right? Or the opposite, mania could also be a thyroid issue. And it's that's just an example, one example in endocrinology. There could be lots of different things kind of going on there. And so don't be oh, if I'm really depressed and I have suicide ideation and I'm just going to buy a lamp. No, talk to somebody. Yes, for sure.
And it's funny that you mentioned the thyroid. We're always told, check the thyroid. The thyroid can do just about anything.
Yeah.
Okay. So with that disclaimer and with that very serious hopefully piece of advice that we can extend to you. Let's think about let's think about schizophrenia, right?
Mm-hmm.
So with schizophrenia, this is often like, this is what people think of when like some say, oh, like psychosis, right? Psychotic. So with schizophrenia, it really is this psychosis that is at the crux of it all. And so folks with schizophrenia, they can have positive or negative symptoms. Now, positive in this case does not mean that they are good. Let's be very clear about that. Yeah. In medicine, positive will often mean it's adding something, right? So it's something that was not initially present that is now added to it. So examples of these are delusions, right? Believing things that aren't true. It's hallucinations, right? Seeing and hearing things that aren't true or that aren't actually present, right? So having difficulty talking and just really your behavior is really erratic. The way you talk is really disorganized. So these would be examples of positive symptoms. But I mentioned that these folks can also have negative symptoms, right? So negative symptoms, what you're seeing, like the affect that I'm presenting to you, right? You can kind of get a gauge of my emotion based off how I'm presenting, right? My external appearance. These folks are going to have flattening of their affect. They might also have just like really hard time talking and thinking. So we talked about maybe that disorganized version, right, where they have extra stuff, but they might also be lacking, right? So they normally are able to have a fluent conversation. All of a sudden, it's not really there for them. This is also a long-term functional impairment. So this is at a 6-month mark is usually the cutoff that's used. So once these symptoms have persisted for about 6 months, then it qualifies for schizophrenia. But these are just some of the symptoms that folks might experience. In general, for schizophrenia, they need to have at least 2 or more positive and negative symptoms. It's not just like, oh, you just hallucinated once, you have schizophrenia.
Right.
That's not how it works.
Yeah. And these things can ebb and flow, and they can get worse for a patient and get better for a patient, kind of like move back and forth. And that's pretty common. Personally, when I think about schizophrenia, like it is just like, we just talked about some of the symptoms there. There's a lot of symptoms that can show up. There's people who like can't move, right? Like they stop using their legs. That would be a negative symptom. Or they do extra movements and they're like always waving their arms everywhere they go. That would be a positive symptom. Or it could be people who echo what other people are saying, which would be called echolalia, which is the symptom there. Or echopraxia, where they are like constantly like mimicking what other people are doing, like physically with their body. And there's a whole slew of these. There's a ton of them. Personally, I think schizophrenia is kind of a catch-all for anything like going on with some psychoses, and we're just gonna call it schizophrenia. But like, it's probably like, because schizophrenia can present in so many different ways. Like you can have like 5 schizophrenics in a room and none of them act the same. And so that's something that is a little bit tricky here. So knowing these, I do want to kind of like take a second and point out like the delusion and hallucination thing, because that's something that like everyone feels like, oh, I perfectly understand this. But then whenever I ask a student, I'm like, all right, give me an example of a hallucination without a delusion. Students always like, oh, wait a minute. And they get like kind of like twisted around, or a delusion without a hallucination. And so they feel like they understand them, but pulling them apart can be kind of tricky. I'm just springing this on you. Azaii, can you give me an example of like a delusion without hallucination, or vice versa, one or the other?
Yeah, so having believing that that the government is listening on all of your conversations, right? You're not actually hearing anything. You're not hearing the supposed people who are listening on the conversation. You're not seeing anyone following you. The moment you see someone following you and thinking that they're following you, that becomes hallucination and delusion put together.
Right.
But just the belief itself, delusion.
Yeah. That's a really interesting one, because paranoia is also another symptom. And so somebody who believes that the government is after them, that is paranoia and delusion. And so that's 2 criteria. So that's enough to diagnose schizophrenia if it's been six months.
Yeah. And I can also, like, if I were right now let's say that I'm a patient in a hospital room, right? If I hear someone talking, but they might not, like, I may not think that they're talking to me. I may not think it has anything to do with me, but I simply hear someone talking, and then we go outside my room and there's no one there. right? That would be a hallucination, but it's not tied to a delusion.
Right. There are also people who are diagnosed schizophrenics and they know that the voices they're hearing are not real. And so they randomly hear laughter. I'm like, I know that's not real. And so if those people are still in touch with reality, they're not delusional, but they're hallucinating because there's sensory information coming in. I think we actually talked about this a little bit with like sensory stuff.
I think we did.
Back in the day, but it's something that once again, like students get tripped up by that all the time. Now there are other types. So like just giving a window into schizophrenia, like there's like the DSM-4, the previous version, there were all these different subcategories like movement based and paranoid based and like disorganized based, like all of these different things. But I do want to kind of like point out the catatonic or movement based things. Now they're all just kind of lumped together as just schizophrenia, because they were it's so hard to like tell the difference between some of these, and sometimes stuff overlaps and sometimes it's multiple, and like it's just kind of a little bit messy. I think schizophrenia is probably one of the messiest diagnosing areas out there currently. But I was watching a TV show about a guy that was like traveling around the country. It's An Idiot Abroad. It's a British TV show. Great show. Overall, it's basically about a guy who hates to travel and his friends are making him travel to all these weird places and stay in awful hotels and like experience things. So like he like really just wants to stay home. And like the whole premise of the show is he hates, it's a travel show by somebody who hates traveling, which is like a very interesting premise. But at one point he goes to India and so it was like a big religious ceremony. And I always have to be kind of careful here because like, yeah, I don't want to say that people who are religious have psychological disorders. I'm not saying that. I'm like, that's not where I'm going with this. But there was a Baba at this place who was a religious figure, and he had his hand raised above his head for like 34 years, and he had not dropped his hand. And so all the blood had drained from that arm. So his arm is actually not usable anymore. Like he can't open and close his hand. And like he had lost function because he'd been holding that one arm up in the air. And I think the idea was that was a way to show, his faith in religion or something like that. But I remember the moment I saw that, I'm like, ooh, that seems like a catatonic schizophrenic, possibly, where there's like something going on with an extra movement where just like the arm is raised all the time. And so that's like, that's always like one of the biggest examples that jumped out to me. I'm like, whoa, that's an interesting catatonic schizophrenic symptom. Now that person might not be schizophrenic, but if I saw that in just the regular population, I would immediately like, ooh, that seems kind of like schizophrenia there. I should probably dive into that. That would be a positive symptom, by the way, an extra thing beyond like the way someone would normally live their life.
Also, just kind of thinking about the prevalence of this, because we've been trying to, the MCAT does want you to know general rates, like, is it common? Is it not common? Things like that. So we said that depression was really common. Schizophrenia is less common. So it's about 1%. It's closer to 1%, which if you think about it is still like Phil said, these are not super uncommon, right? If you put a room with 100 people in them, one of those people, might end up having schizophrenia. And something else with that, right? Like if you think about some of the med school classes that you're going to be in, right? Some of the med school classes are about 100 and change, almost 200 students per class, right? Per year. So by chance, it is likely that one of your classmates, someone in your cohort, may have schizophrenia, right? Many of, people in your cohort may have depression. A handful of people in your cohort might have bipolar disorder. So these are all, they're rare, but they're not as rare as we might think. And hopefully that puts things into perspective. Now, right. As I was saying that, I had another thought that I want to mention. So you'll notice that as whenever we can, we're trying to use language like, oh, the person has this disorder. And this is something you'll learn about in medical school. And as you continue going, it's called person first language, prioritizing like the person and not the disease.
I need to be better at this.
Oh, I've been trying to retrain myself, because it's like, that's the way that we've, many of us were raised or interacted with society. It was like, oh, like that person is depressed. Like they're like a depressed person. Yeah, a depressed
Or,
person. There we go. That's what I was
as
looking
I'm
for.
pretty sure I said a moment ago, a schizophrenic. Instead, I should phrase that as a person who has schizophrenia.
And
Just kind of
all
like
that to say, like,
labeling.
we're not immune either.
No.
Like it slips. But I just want, like, as you guys are going into your future careers, just kind of keep that in mind, and making sure that you're treating the depression, or the disorder, right, in the context of the person. Same with like the conversations and things like that. But we are all learning. We are all doing our best. So be kind with each other and with us if and when we slip up.
Yeah, be better than us, which is always my argument to everyone all the time. Be better than I am. Like, here's what I'm trying to do. Try to be better than me. That's an older brother thing, like talking to my siblings. I'm like, yeah, I know I screw up sometimes. You should be better. You should learn from me and then everything else. But I do want to point this out because I know a lot of you guys are like, I feel like these rates are way off. If you have psychological disorders, you have trouble very often succeeding. Note that this is how these things are defined, as we talked about. Like, it's defined about a lot of these about how they interfere with your life. And so if somebody has a very severe psychological disorder, they're probably not going to make it into med school because that already is such a difficult path to get through. Now, some of the more common ones like depression, like absolutely there are people in med school with depression. There are people in med school with bipolar. Schizophrenia is a little bit harder to do, but that doesn't mean that these people don't exist. And in certain populations, you will see way more of these and way less. Like, I guarantee if you looked at the homeless population, the rate of schizophrenia is not 1%. The rate of schizophrenia is going to be sky high in comparison to the average population. And that's why they end up homeless, is because they have these psychological disorders are interfering with their life to such an extent that they can't manage their homes and like, finances and things like that, which might also happen, as we mentioned, with bipolar, right? Someone who's extreme, someone who has an extreme manic, I'm working on it, who has an extreme manic, episode is likely to risk all their money and like lose it in some way. And so now they can't afford their rent. And so now they're homeless. And so note that like these numbers, there's a good chance that if you've made it this far in your life and you're going to med school and you're going to be a physician, that you have not been exposed to a lot of those places. That doesn't mean that these don't exist and these diseases don't exist. And there's a lot of them out there. And a lot of homeless, I'm sure, are a lot of homeless people. I'm working on it. Are not only have schizophrenia, but a lot of them are undiagnosed as well. And so just kind of like factoring that in, just because you don't see these people doesn't mean that they don't exist. And that's something that is really important as a physician. I promise if you work in a free clinic in a major city, you're going to see a lot of these and you'll start to realize just how common these things actually are. Did you have something you wanted to say there? You kind of looked like
just that with like appropriate treatment and medication and support, a lot of people with these disorders, right, given the right support, can live really fulfilling lives and,
right.
Go on and, for example, do medicine, right, or become doctors.
Right.
Keeping in mind that, right, medication is not foolproof. So even if a patient is doing their absolute best, taking their medication every single day, they might still have, episodes where the disorder breaks through and things like that. But people can have very fulfilling lives with these psych disorders.
Yeah, especially talking about the biopsychosocial, like added stress and stressors can affect things a lot as well.
Mm-hmm.
There's also something called schizophreniform disorder, which you can kind of like shortcut it as just it's schizophrenia light. So it tends to be a little bit less severe in terms of, I think, both duration and symptoms. And it can be kind of passing. A lot of people who have schizophreniform disorder eventually develop schizophrenia. Not always, but sometimes. And that's something that can occur. And there's also something called schizoaffective. So there's schizophrenia, schizophreniform disorder, and schizoaffective. Got to be careful because there's also like later on, we'll talk about like schizoid and schizotypal personality disorder, and all these words kind of sound the same. So just to reiterate, schizophrenia is what we've been talking about. Schizophreniform is like the weaker version of schizophrenia, and schizoaffective mixes the like schizophrenia with mood disorders. And so the affect, the mood side. So if you have schizophrenia and a like mood symptoms, well, we don't just call that schizophrenia. It's kind of its own special disease, kind of categorizing this. Honestly, whenever the DSM-6 comes out, I feel like a lot of these are going to get reshuffled around again, as they pretty much do every time a DSM new version comes out. But for now, schizophrenia, schizophreniform disorders, and schizoaffective disorders, all under that realm of schizophrenia.
Yeah, with schizophreniform. So you heard us say that for schizophrenia, right? It's about a 6-month cutoff. If the person has symptoms for 1 to 6 months, basically, that's like schizophreniform. And like you were saying, I think it's about 2/3 of people with schizophreniform eventually get diagnosed with schizophrenia. So it's a pretty high number. And then yes, with schizoaffective. So just to add one thing, right, in terms of why this might be classified as separate from schizophrenia, you also have to treat depression. Right. So you have to treat the bipolar, you have to treat the mood disorder. And so clinically, that's some of the usefulness as to why to distinguish between the two.
Right. It's useful for a physician to remember, like, because a lot of times the schizophrenia is the predominant symptoms that you see. Like if like a lot of times depression is hard to see. Like it's hard to see depression, which is why even though it's really common, it is way underdiagnosed and undertreated. And so like if somebody has schizophrenia and that's really apparent, but they also have depression, like it's really easy to miss that depression. So like when we label this and diagnose it, we're gonna call it a different disease so that you don't forget as a physician that there is also a mood disorder here. I feel like that actually might be some of what's going on there, is just like a way to help physicians, communicate a little bit better.
For sure. Well, thank you folks for coming on this journey with us, talking about the mood disorders. Don't let the MCAT get you down, right?
Right. Buy a lamp.
But next time we'll keep talking about some more psych disorders. So stay tuned for the next episode.